Neha ji, you can unmute your mic right now.
Okay, thank you. Hi, Dr. Jindal, Dr. Zarir, and Dr. Zafar. Good evening. Neha this side from Boringar.
Yes, hello Neha. Thank you. Nice meeting.
Good evening.
Good evening, sir.
So, how is COVID in Mumbai this time? You see now.
Sir, this question is for Dr. Zarir.
Yeah, Zarif, I think he has gone to take his cup of coffee.
Yeah, I think most of the people have already got it and got the experience of COVID and now
Quite right. You see.
sort of quarantining, like working from home for us.
Yeah, I can understand. In fact, that's true for most of us. Although we are now, especially people like Zafar, are always in the ICU.
Over 9 months now, sir.
Yeah.
So,
I'm just listening to the news now that the vaccine will be available from next week, 16th onwards. You've seen.
So they're still awaiting some clearances and all, sir. So I just hope that clearances are not a hindrance or delaying tactics.
Yes.
So dates, I don't know how to believe in these dates, but yes, it's highly awaited.
I think we have now Randeep here, so he can verify as to the date, you see. Hello, Randeep, welcome.
Good evening, sir. Good evening to everyone.
Good evening.
Everyone.
Good evening.
Good evening, sir.
We're just discussing that the vaccine will now be available from 16th onwards. That's what...
I believe that's the announcement, sir, that it will be available from 16th onwards.
Yes, I think that's true. So by the end of the month, I think there should be a significant number of people who are vaccinated.
It will depend on the number of doses and how we roll it out, sir. In our country, significant is considering our population depends on numbers actually.
Yes, of course, that's true.
Some news from Madhya Pradesh regarding COVID, post-COVID vaccine issues. Some mortality has been reported, sir. Is that true?
Not that I'm aware of. There was one.
There was a news flash today evening.
It was on the news, but they say it was unrelated and happened after 8 or 9 days. Possible case of poisoning.
9th day post-vaccination.
Possible case of poisoning. That's what
documented as possible poisoning, sir, as far as I remember.
I think they're just trying to derail things, sir. Nothing else.
Should we start?
Sir, Neha?
Hello, Mr.
Sure, sir, we can start, sir.
Kash.
Yes, sir. I think we can start
Sure, sir,
because it's already 7:02. We can start.
Okay. Hello, everyone. I'm most pleased to welcome you all to this webinar on pulmonary fibrosis. Interstitial lung disease in general and pulmonary fibrosis in particular has become very important these days, you see. There is an increased recognition and in fact there is hope of treatment now. Earlier it was a kind of dismal treatment. Now we have at least some hope, you see, some reduction or decline in mortality and other things. But this COVID issue has in fact increased the burden even more and has put a lot of questions on the diagnosis as well as on the management of pulmonary fibrosis, which has been existing previously and also which has been induced by the infection itself. Today we have very eminent people as our speakers. Dr. Randeep Guleria, the Director, All India Institute of Medical Sciences, New Delhi, is a household name now. He is in the forefront in the fight against COVID, and you can see him almost every day uh, on the national TV with some or the other kind of good news or sometimes bad news about the disease. You see, besides being a kind of a frontline fighter, he is an eminent pulmonologist and a teacher of medicine, and I'm sure we will learn a lot from him as far as the pulmonary fibrosis or idiopathic pulmonary fibrosis is concerned. We also have Dr. Zarir Udwadia, who's a senior consultant at Hinduja Hospital and Research Center, as well as Breach Candy Hospital in Mumbai. He's an equally eminent pulmonologist and with a large experience in COVID fibrosis, you see. So I'm sure he's trying to solve a lot of our, if not solve, at least will bring to the discussion a lot of the issues related to COVID fibrosis. Followed by this, we'll have a panel discussion to answer some of the questions which are raised by the audience as well as by others on these two issues, you see. And on the panel, we will have, in addition to Dr. Guleria and Dr. Zarir Udwadia, we have Dr. Zafar Iqbal from Fortis Hospital, Mohali, and Aditya Jindal from Chandigarh, you see. So without any delay, I'd like to welcome the panelists, and I'm grateful that they have kindly agreed to spare their time for this meeting. First, I'll request Dr. Randeep Guleria to talk about the idiopathic pulmonary fibrosis in general. I think we'll have discussion. We'll have each talk for about 35, 40 minutes and followed by discussion for another 30, 40 minutes, you see. After the talks are over. Professor Guleria, please.
Thank you, sir. Thank you very much for inviting me for this national webinar on idiopathic pulmonary fibrosis in COVID-19 era. I'll just share my slides. I hope my slides are visible.
Yep. Yes, very nice. Yep.
So thank you very much. And I shall be focusing on IPF, both what we know and then how has COVID-19 impacted both our diagnosis, management as far as idiopathic pulmonary fibrosis is concerned. Now, so the current overview of my talk would have two broad top areas. One was the current management update on the management of IPF 2020, which we look at what do we currently know, touching upon the clinical, radiological and pathological diagnosis, the role of antifibrotics, and also vaccination, pulmonary rehabilitation and lung transplant. And then, like I said, management of IPF in our current situation with COVID-19 pandemic and clinical aspects, management both of IPF during COVID-19 and COVID-19 in an IPF patient. So to begin with, the current update, we all know that idiopathic pulmonary fibrosis is a chronic fibrosing interstitial lung disease, which belongs to this broad family of IIPs, the idiopathic interstitial pneumonias. And depending on various registries, this is a hot topic of debate. The incidence can vary from 20 to 40% of ILD patients who get diagnosed depending on which center you are and what is your referral bias. Diagnosis of IPF is multidimensional and multidisciplinary. This is what we have learned now over the last, I would say, more than a decade, that it has to have a pulmonologist, a radiologist, a pathologist, and a thoracic surgeon all coming together and working as a team to really make a diagnosis of idiopathic pulmonary fibrosis. So this is the broad criteria of the interstitial lung disease. And among them, we have those of which we know a cause, which could be CT-related ILD, drug side effect, or those which we don't know a cause but are granulomatous in nature, like sarcoid. At times, we know the cause of hypersensitive pneumonitis. Some other forms like lymphangioliomyomatosis and histiocytosis X. But the bulk of them usually come under the IIPs. And the major ones are the chronic fibrosing ones, the smoking related, and the acute and subacute ones. And among the chronic fibrosing, the idiopathic pulmonary fibrosis is the dominant one. We have NSIP also there, and then we have the smoking related, which is the ILD and the DIP, and of course the acute and subacute, the COP, the cryptogenic organizing pneumonia, and the acute interstitial pneumonia, which we see, and at times even COVID presents as an AIP sort of manifestation. Now, if you look at what is the existing paradigm of interstitial lung disease diagnosis, and this is what was being done even in the pre-COVID era, and in that the diagnosis of ILD required a very close integration of clinical, radiological, and pathological information, and this was through a face-to-face, multidisciplinary discussion at an experienced ILD centers. We would sit with the radiologist, spend quite some time looking at the CT scan, or we'd have our so-called histopathology round, where the pathologist would also discuss the pathology findings, and that would be done. So a clinician would look at the history and physical examination, the pulmonary test, and the lab investigation to rule out known causes of interstitial lung disease. The radiologist would look at the HRCT, and if we had tissue diagnosis either by a surgical lung biopsy or a cryobiopsy, or at times if it was not possible, even a bronchoscopic transbronchial lung biopsy was looked at times, and based on that, a diagnosis was usually made. And this was based predominantly on the paper published in the Blue Journal in 2018, which was basically on behalf of the American Thoracic Society, the ERS, the Japanese Respiratory Society, and the Latin American Thoracic Society. This had therefore focused a lot on the CT scan and divided the pattern on CT as a UIP, probable UIP, intermediate UIP, and then had put in what was then added as an alternative diagnosis. And in the UIP was subpleural and basal predominant, distribution was often heterogeneous, and the other essential component was honeycombing with or without peripheral traction bronchiectasis or bronchiolectasis. And in the probable UIP, it was predominantly the same, except for the fact that honeycombing may not be present, and you may have mild GGOs also present, and that would still make it a probable UIP pattern, which was something that one would have thought of in the past was something which took you against the diagnosis of UIP. And then we had the indeterminate for UIP, which was subpleural and basal predominant, but there was some degree of reticulation and mild GGO or distortion. And then we had the alternative diagnosis, where you had the 7 criteria on CT, the cyst, mosaic attenuation, predominant GGOs, profuse micronodules, centrolobular nodules, even if there were other nodules and consolidations, which took you towards an alternate diagnosis. And then it also looked at the distribution, if it was peribronchovascular, perilymphatic, and more of upper or mid-lobe dominant. Again, you would start looking at an alternative diagnosis. And in this, they also sort of looked at things beyond just looking at the lung parenchyma. So pleural involvement, dilated esophagus, and other things were also added on to really make a comprehensive view of the CT scan to try and see whether it is UIP or there could be an alternative diagnosis. So UIP pattern was, like I classically said, the classical honeycombing, subpleural basal distribution, and a lot of studies then showed that the positive predictive value of a radiological diagnosis of UIP on HRCT for a pathological diagnosis of UIP was between 94 to 100%, although the sensitivity was much lower. We had the probable UIP pattern, again, that I mentioned, and here the positive predictive value based on the radiology of probable UIP on HRCT for a pathological diagnosis of UIP was between 82 to 94%. So again, quite an acceptable positive predictive value. When we looked at the indeterminate for UIP pattern on CT scan, it had a positive predictive value was able to have a diagnosis of UIP or IPF was only about 30%, in about 30% of cases. And then alternate diagnosis obviously gave you a different type of picture. And here in a minority of patients, the histopathological diagnosis may have been suggestive of UIP, but the CT pattern was definitely a non-IPF diagnosis. And this led to the classical diagram where you had a histopathological pattern and the HRCT pattern. And based on that, one would look at a UIP pattern, a probable UIP, indeterminate, or alternate diagnosis. What this highlighted was that a definite UIP pattern on CT obviates the need for histological diagnosis if you have ruled out other causes, and the clinical profile of the patient also fits into an IPF picture. Moving on to pharmacotherapy of IPF, the antifibrotics. Now, we have really seen a lot of evolution as far as the treatment of idiopathic pulmonary fibrosis is concerned, from an era of the triple therapy of steroids, immunosuppressant, N-acetylcysteine, to a lot of controversy regarding these drugs and which immunosuppressant was better. The previous studies, even a long time back, was showed that cyclophosphamide may be better. Then we moved on to azathioprine, and the dose of steroid was something also which was debated: should you give a low dose or higher dose? But I think we've really crossed all of that, and currently we know that based on the pathophysiology, the treatment strategy is basically on to focus on antifibrotics. And two antifibrotic drugs, pirfenidone and nintedanib, have been shown to be safe and efficacious in the management of idiopathic pulmonary fibrosis and even in the fibrotic interstitial lung disease. Both have shown to slow the rate of FVC decline by approximately 50% over the course of 1 year, and have shown efficacy in reducing severe respiratory events such as acute exacerbation and hospitalization for as far as respiratory events are concerned. And I'll just quickly discuss the main trials. This was the ASCEND trial, which was a phase 3 trial of pirfenidone in patients with IPF, around 555 patients in a randomized controlled trial. And the primary endpoint was a change in FVC, that is a decline by 10% or death at week 52. And they looked at many secondary endpoints like the 6-minute walk distance, progression-free survival, dyspnea, and death from any cause or IPF. And classically showed that the arm that got pirfenidone, there was the decline in FE1 was much less as compared to the placebo arm, and even progression-free survival was better to some extent with the pirfenidone as compared to the placebo. There was also the 6-minute walk test, and was also showed better better improvement as compared to the placebo arm. Similarly, the 3 studies, the Impulses trial, which looked at nintedanib in IPF, they were phase 3 randomized controlled trial over 1,000 patients, and the primary outcome also looked at annual decline of FVC measured in ml per year, and the secondary outcome was the time to the first acute exacerbation, and also change from baseline in total score of the St. George Respiratory Questionnaire. Both the Impulses 1 and Impulses 2 actually showed that nintedanib did better in terms of the annual rate of FVC decline, which was statistically significant, and the pooled data also supported that. When we looked at the secondary endpoint, then Impulses 1 did not reach the required significance in terms of time to exacerbation or risk of exacerbation. But that was shown in the Impulses 2 trial, that there was a significant decrease in the time to exacerbation and also a decrease in the risk of exacerbation. And the pooled data also tend to show that this was statistically significant. So if you looked at the cumulative incidence of exacerbation, the Impulses 1 did not show any significant, but there was quite a big difference as far as Impulses 2 was concerned, and that added on to the difference that came up when the pooled data was analyzed. There's also other studies. This looked at the effect of pirfenidone on mortality, and this was again a pooled analysis and meta-analysis of clinical trials of IPF. This combined the capacity and the ASCEND trials and looked at mortality at 52, 72, and 120 weeks. And at 52 weeks, there was a reduced all-cause mortality in the pirfenidone group, and even at 120 weeks, there was a reduced mortality in pirfenidone group. And this was the data that they said that pirfenidone therapy is associated with reduction in relative risk of mortality compared with placebo over 120 weeks. So again, very encouraging data to suggest that pooled analysis did have some mortality benefit also in addition to sort of declining or preventing the decline in vital capacity. So when we looked at the two antifibrotics. This is just to summarize the pharmacological drugs which are there: nintedanib and pirfenidone. And nintedanib, we all know, is a TKI, tyrosine kinase inhibitors, whereas pirfenidone has multiple actions. It inhibits TGF beta and also has some effect in terms of fibroblast proliferation. Both have been shown to slow the FVC decline by 50%. There are significant side effects. Many patients have had to stop the dose because of side effects, diarrhea with nintedanib, and a lot of anorexia, weight loss that we see in our patients with who have to take who sort of reach the full dose of pirfenidone. There are side effects which we need to monitor also as we give these drugs. But there has been no head-to-head trial which compares nintedanib versus pirfenidone. There's one study in chest which sort of like to look at looking at what was looking at network meta-analysis, and this tried to identify all pharmacological treatment evaluated for IPF and analyze their efficacy by Bayesian network meta-analysis and a pairwise indirect treatment comparison. And what they concluded was that for respiratory specific mortality, all-cause mortality, and decline in percentage predicted FVC, nintedanib and pirfenidone were virtually indistinguishable, and no clear advantage was detected. So this paper really looked at it critically, and showed that both drugs were equally effective in all the parameters that they tried to study, whether it's mortality, decline in percentage predicted FVC. There was really no difference at all. So I think both drugs are relatively equally effective. But there are also certain drugs which are not recommended, or again strong recommendation against the use which was there initially. If you look at anticoagulations and combination, currently there are strong recommendation against their use. And nintedanib and for pirfenidone, the guidelines then said there was conditional recommendations for the use. So it's important to keep these factors in mind as far as the current practice guidelines are concerned. Coming to vaccination, I think we all know that patients with IPF are at increased risk for invasive pneumococcal infection, including community-acquired pneumonia. And they have more than twofold hospital mortality with community-acquired pneumonia as compared to controls. Hence, they should be given the pneumococcal vaccine and the yearly flu shot as a standard practice. And it has also been now mentioned that patients with IPF should also be considered a priority group for COVID-19 vaccination, which is going to be rolled out in a week's time. So I hope that priority group is there. We've been involved in making criteria, and obviously IPF is in the older age group predominantly, and they are going to get vaccinated even because of the age and the comorbidity that they have. But ILD patients in general who are even less than 50 years of age, sort of a matrix has been created, as has been created for other diseases, that if you have a patient with ILD who is on long-term oxygen therapy or whose vital capacity is less than 50%, he goes onto the priority list as the topmost priority for the vaccine therapy. This is a grid which has been created by multiple groups. The group that has looked at chronic respiratory diseases, basically Ashutosh from PGI and Dr. Anantmohan from AIMS. And we've all correlated that with other groups, whether it be the cardiac group, the diabetic group, or the renal group, or the disability group. And a matrix has been curated, which has now been presented to Niti Aayog to look at and talk to states as to how we could look at this in the long term when we start looking at vaccinating people with comorbidities less than 50 years of age. Coming to role of pulmonary rehabilitation in ILD, pulmonary rehabilitation again is safe for people with ILD. It's been shown to be to have improvement in functional exercise capacity, dyspnea, and quality of life. And this benefit is also evident in patients with IPF. And I would strongly urge that we should consider a pulmonary rehabilitation program early rather than late in patients with ILD and IPF. There is a Cochrane review which has looked at pulmonary rehab in ILD and shown that there is benefit as far as 6-minute walk test is concerned as for pulmonary rehab versus no pulmonary rehab. Dyspnea scores are also much better as far as pulmonary rehab is concerned versus no pulmonary rehab. And also, if you look at quality of life, there is definitely an improvement in quality of life in this Cochrane review as compared to no pulmonary rehab. So there is enough data for us to support the use of pulmonary rehabilitation in patients who are having uh, interstitial lung disease and IPF. Lung transplant, the general criteria for lung transplant, now that it's being done in our country, is that if there's risk of death for lung disease without transplants is more than 50% in the next 2 years, and the likelihood of survival at least 90 days after lung transplant is more than 80%, one should consider it. There should be absence of non-pulmonary medical comorbidities that limit life expectancy substantially in the first 5 years after transplant. So you should not have comorbidities which will decrease your life expectancy in the first 5 years. And of course, the NYHA functional class 3 and class 4 are considered indications for transplant. If we look at the International Society for Heart and Lung Transplantation data, diffuse parenchymal lung disease now is the second most common indication for lung transplant, followed only by COPD. And therefore, it is becoming a more and more important cause of lung transplantation. In my experience, patients with interstitial lung disease are more forthcoming to get a transplant done rather than COPD patients who would sort of delay it much more because they would continue their long-term oxygen therapy and still feel that they may be able to manage. But ILD patients are those who really are more forthcoming for. We all know the referral criteria, but again, like starting early in pulmonary rehab, sensitizing patient for lung transplant should be done early. If you have a histopathological, radiological, UIP or NSIP pattern, if your FEC is on the decline, if there is any dyspnea or oxygen requirement, it's important to start talking to the patient and talking of referral as far as lung transplant is concerned. And then you have a classical listing criteria depending upon the change in your lung function or the desaturation and presence of pulmonary hypertension and other features like acute exacerbation. So what are the outcomes? Patients with IPF have the highest mortality rates among patients on the waiting list for lung transplant. So they are the ones who need to really be taken up early because many of them will die while waiting for a lung transplant. And the 1 year survival in this large study was close more than around 74%. And there is data which looks at 10-year survival in patients with IPF, and median survival of 10 years following lung transplant for IPF has been reported, and it has been found to be better in those who had a bilateral lung transplant uh, in this group of patients. So there is now good amount of data emerging that patients with IPF who are having a progressive decline should be considered for lung transplant. We must accept the fact that all the drugs that we give can slow the progression, but it's not that they will not progress to end stage lung disease and may need a transplant. Coming to the second part, that is managing IPF patients in the new normal, it's become a big challenge for us. And the first question is, why do IPF patients deserve special consideration in the COVID era? The risk factors in IPF patients for severe COVID-19 are definitely there. They tend to be older, like I said, and are predominant males. They have multiple comorbidities and they really don't do well. I still have one patient who is admitted for almost now 3 weeks with IPF and COVID-19. Again, the issue that this patient raised was that he never went out. He stayed at home. He's on long-term oxygen therapy. Why did he get COVID-19? We must understand that a lot of people who may come inside may have mild symptoms or be asymptomatic and can still give the infection. And therefore, COVID appropriate behavior should be there for everyone. The patient is still on high flow nasal cannula, although it has come down, the requirement has come down, but is going into some degree of depression and anxiety because he's not able to meet family members because he's in a COVID hospital and there are anxiety concerns that patients have. So these patients also have multiple comorbidities, and they have similar ill effects of ILD and COVID-19 exist. Both of them cause respiratory failure and hypoxemia, and there's always this issue that can COVID-19 itself be a cause of acute exacerbation of idiopathic pulmonary fibrosis. There is this paper which came up quite early, which looked at clinical characteristics of COVID-19 in patients with pre-existing ILD. This was from Wuhan, China, and they looked at around 28 COVID-19 patients who had pre-existing ILD and compared that with non-ILD controls. And what they found was that these patients had more cough, more sputum, fatigue, and dyspnea. The levels of inflammatory markers were much higher in them. They had more severe disease, and as can be seen, the outcome was poorer in them. The mortality was much higher in these patients as compared to those who did not have interstitial lung disease. There's also this paper which has come out in the Blue Journal, which is it came out in October, which looked at outcome of hospitalization for COVID-19 in patients with interstitial lung disease. This was an international multi-centric study from Europe. They looked at about 350 patients with ILD across Europe were included. 161 of these were actually admitted with COVID-19, and they did a propensity score matching as far as the study was concerned. The overall mortality was 49%, very, very high. After matching, ILD patients had higher mortality when they compared with age, sex, and comorbidities matched controls. This was also significant. And patients with a vital capacity of less than 80% had increased risk of death as compared to those who had a forced vital capacity of more than 80%. And another risk factor that came out was obesity. So what they found was that as compared to no ILD, the ILD group did worse, but those who had IPF actually were the one who did really bad. And then if you had obesity, again, you were having a poorer outcome. And if your FE, if your forced vital capacity was less than 80%, then also your outcome was much lower. So all of these factors were associated with poor outcome as far as IPF and COVID-19 is concerned. So what they concluded was that this study demonstrates that patients with ILD are at a higher risk of death following COVID-19 than matched patients without ILD. And the risk factors for death include male sex, an FVC of less than 80% predicted, and obesity. So there is now data emerging that people with interstitial lung disease do have a poorer outcome. So what do we do as far as COVID-19 and the pre-existing ILD patient is concerned? The challenges of diagnosis and management of ILD becomes a big issue as far as these patients are concerned. And this has been addressed by various groups. These are the recommendations of the American College of Chest Physicians, which looked at practical consideration for diagnosis and treatment of fibrotic interstitial lung disease during the COVID-19 pandemic. There's also a nice guideline, the National Institute of Health and Care Excellence Guideline, which is also on COVID-19 and interstitial lung disease, and also a guideline from the Canadian Thoracic Society, which has also looked at optimizing care for patients with interstitial lung disease during COVID-19 pandemic. So if you look at the paradigm, like I mentioned, the diagnosis of ILD really required clinical, radiological, and pathological involvement. But most of them, whether it be PFT, lab investigation, CT scan, or a biopsy or a bronchoscopy, needed physical visits to hospital or a healthcare facility. And also data suggested that the median delay in diagnosis from symptom onset was typically over 1 year. And delay was likely to increase further with reduced access to diagnostic tests and outpatient care due to the pandemic. So this became a big challenge as far as the diagnosis of interstitial lung disease and IPF is concerned. So what this is the standard chart which shows the flow chart as far as the standard approach is concerned. Whenever we have a patient who has suspected to have ILD, we do a clinical evaluation, history and physical examination, do various tests to rule out a secondary cause. Classically, a CTD serology is done, an HRCT is done, and a lung function is done. And then based on that, if a potential cause is found, you may find that this patient may have a classical features to suggest a connective tissue disorder, then it is not IPF and a specific diagnosis started. Or the HRCT, if that is not there, HRCT is done. If it shows a classical UIP pattern, you may consider IPF. But if it doesn't fit into that criteria, then invariably this patient goes into what is a multidisciplinary diagnostic approach, and an alternate diagnosis is considered. Very often then you may consider a procedure. It could be a biopsy or a lavage. And then based on that, it's again discussed, and a provisional diagnosis is made or unclassified ILD diagnosis is made. Now, what has happened as far as the COVID-19 is concerned? What can we do to prevent delay in diagnosis and management while avoiding non-essential contact with the healthcare system? One is the outpatient care. The most important thing is stagger appointments to avoid excessive waiting time and crowding. Use telemedicine, and this is something which has really made a big difference in our follow-up of ILD patients where it's justifiable. If, as far as investigations are concerned, use of outpatient or mobile labs rather than hospital labs because the chance of exposure are higher there. Radiological examinations only when it is necessary, and avoid routine PFT follow-up when your COVID cases are high in a particular area. And the role of virtual MDD is becoming more and more important. Consider empirical therapy based on clinical radiological diagnosis, deferred bronchoscopy, or surgical lung biopsy where reasonable till the pandemic lasts. There are a lot of things that have been looked at. This is one paper which looked at home monitoring in patients with idiopathic pulmonary fibrosis. This is a randomized controlled trial. The sample size was small, but they really looked at could they do home monitoring of their patients. And what they found was that there was a good patient experience. A lot of patients said that they would recommend it to others, or they got a better insight and they felt reassured. So this paper did suggest that there is a role of home monitoring in patients with idiopathic pulmonary fibrosis, which could be one way forward in the COVID-19 pandemic. And maybe later on also one could look at how this could be done in terms of better patient care without them having to come to the healthcare facility. There's also a paper which looked at home monitoring in patients with ILD and COVID pandemic, which looked at different ways of doing it, not only the program mode, but looking at spirometry, a portable spirometry, which is available. This spirometry is available in our country also, which can be linked on to your smartphone. And the data is actually comes onto the smartphone, and then it can be using Bluetooth can be sent to the physician itself. So there are a lot of innovations which are now available where you can get some degree of clinical data from the patient, which may help you in monitoring patients at home with interstitial lung disease. As far as spirometry is concerned, there's been a lot of other things that have been tried. This is from Italy, where they've looked at changing the PFT room and resuming outpatient services, where they have put in a plexiglass between the spirometric machine and the mouthpiece, and the patient comes in from one side, the technician is here, and there is good cross ventilation with the exhaust fans out here, and with that the chances of infection to healthcare workers becomes less. So the recommendations of the American College of Chest Physicians is that the initial consultation preferably should be by video conferencing, complete 1, 2, and 3. That is as far as our initial work is concerned. In most patients, defer 4, that is PFT, in most patients, given the risk of aerosol generation, and hold MDD virtually with at least one ILD clinician and a chest radiologist. And this will help in making a diagnosis without really having to have a physical meet per se. The Canadian Thoracic Society also recommends the same. What they say is that we suggest conducting virtual multidisciplinary discussion using platforms that allow imaging and pathology to be shown in real time, and that really may help as far as this is concerned. Then consideration regarding the pathological diagnosis of ILD during the pandemic. Again, one must take a risk-benefit assessment of biopsy for ILD diagnosis, and this should be considered carefully because of the pandemic. Avoid biopsy in older persons who may develop more severe COVID-19, and we must do a temperature and screening and a COVID-19 test at least 48 to 72 hours prior to the procedure, and aerosol precautions should be taken to protect staff and other patients. Again, if you look at the guidelines, they would really say defer BAL and surgical lung biopsy in most patients, consider methods to mitigate aerosolization during necessary invasive procedure, and reassess patient post-COVID-19 pandemic to determine risk-benefit of additional tests that might increase the diagnostic confidence. So by and large, a lot of patients one would have to start managing without going in for a lot of invasive procedures. And this is also what the Canadian Thoracic Society says, that beyond the usual risk benefit consideration, additional risk factors associated with transmission of SARS-CoV-2 and development of severe COVID-19 illness should be considered when contemplating aerosol generating medical procedures such as bronchoscopy and surgical lung biopsy. So I think there's a lot of caution that has come in as far as these procedures are concerned. Coming to the treatment, now a lot of treatment that was given, it's not really for IPF, but for ILD, and sometimes when the diagnosis is not clear, continue to be steroids or steroid sparing agents, and immunosuppressive medication we know may result in more severe respiratory viral illnesses. However, there is paucity of evidence to guide immunomodulatory therapy during COVID-19. One important issue that one would like to flag is timing of corticosteroids for COVID-19 in the IPF patient. Steroid is the only therapy which has been shown to reduce mortality in patients with severe COVID-19. We know that this is something that has been shown in the recovery trial and has really changed the way we practice as far as managing COVID-19 is concerned. But it's very important to see the group which really benefited, those who had requirement of oxygen or those who were more sick and requiring mechanical ventilation. And steroids early in the course of illness may prolong viral shedding in COVID infection. And therefore, it's important to really time the steroids in these patients very, very carefully. Prior to COVID-19 infection, patients with ILD may already be on steroids and on long-term oxygen support. Hence, the timing and dosing of corticosteroids in ILD is contentious, and steroids are more likely to be useful in persistent inflammation beyond early infection. This is a paper which came up, which looked at during the SARS outbreak in 2004, which looked at early corticosteroid on plasma SARS-associated corona RNA concentration in adult patients, and it measured the efficacy of early steroids and also measured serial plasma SARS-CoV RNA concentration. And what they showed was that the viral concentration during the second and week 2 and 3 was higher in patients who were treated with early hydrocortisone compared with placebo. And early corticosteroids may worsen outcome in coronavirus diseases. This is also somehow, to some extent, given a little bit of, it comes out a little bit in the recovery trial also, because although all participants did show benefit as far as mortality was concerned, if you looked at those who were not on oxygen therapy, the group which received dexamethasone actually did worse as compared to usual care. So it's trying to suggest that giving early steroids when there is viral replication going on may actually be more harmful, and we need to be very conscious of that. On the other hand, those who were on oxygen had really shown a more advanced disease. Steroids did help, and those who were in invasive mechanical ventilation also did have a benefit from corticosteroids. What is the recommendation from the American College of Chest Physicians? They say that in the absence of evidence, a balanced approach towards use of immunomodulatory therapies is necessary. Starting immunomodulatory medication in progressive disease, usually treated with such medication, use may remain reasonable. Limit use of corticosteroids and prioritize steroid-sparing agents. And patients who are already on immunomodulatory medication, consider dose reduction of steroids and prioritizing steroid-sparing agents, and avoid rapid taper, which may result in disease flare. And the Canadian Thoracic Society suggest that immunomodulatory therapy should continue to be prescribed according to standard practices using the lowest effective dose, and temporary cessation of immunomodulatory therapy should be considered on a case-by-case basis in patients who have confirmed or suspected COVID-19 infection. Coming to antifibrotics, current antifibrotics that we give for IPF include pirfenidone and nintedanib. We've already covered this. There's no evidence till date that they influence the severity of COVID-19. There may be an overlap between medication adverse effect in COVID-19 manifestation. We know that COVID-19 can lead to diarrhea, fatigue, loss of appetite, and there can be lymphopenia. However, still, antifibrotic therapy may be initiated and continued as previously indicated for COVID-19 patient, but we must really monitor more aggressively for side effects and also monitor these patients more aggressively using telemedicine. The Canadian Thoracic Society also says the same, that we suggest that antifibrotic therapy should continue to be prescribed according to clinical practice guidelines and recommendations. Now, looking at the approach to COVID-19 diagnosis in IPF, again, in a patient with IPF. Patient with IPF with new fever or mild change in respiratory symptom, one should have a lower threshold than in the general population for diagnosing COVID-19. And telemedicine consultation for screening for need of emergency room visit should be done early. From experience, I can tell you that very often their oxygen saturation just crashes, and therefore you must follow up your patients very closely. Slight fever and a decline in the oxygen sats is something that should sort of warn one to ask the patient immediately to come to the emergency department, because they're on the steep part of the oxygen desaturation curve and it can lead to dramatic fall in oxygen saturation. So urgent medical attention should be sought for patients with more than mild symptoms, and you would require to test them early using either the RT-PCR based test, the CBNAT test, or the rapid antigen test. And sometimes it may be worthwhile to look at multiple anatomical sites for testing. Challenges that we have in continuing antifibrotics, one, of course, like I said, overlap of medication adverse effects and COVID-19 symptoms. Pirfenidone to be avoided in those whose the GFR is less than 30, and should be avoided in both the drugs should be avoided if there is liver dysfunction, and many of our COVID-19 patients may have alteration in liver enzymes, and that is something that we need to keep in mind. Nintedanib may increase risk of bleeding in conjunction with anticoagulants, and that is also something that we need to keep in mind. Mechanical ventilation, this is something that we have to keep in mind, because the overall prognosis is not good, especially in patients who have underlying IPF. We would try and avoid it and give a lot of non-invasive ventilation or high flow nasal cannula. And what is usually said, mechanical ventilation patient with advanced ILD and severe COVID-19 may not be appropriate where lung transplant facilities are not available. And therefore, one should consider establishing advanced care directives in such a situation. And this has been brought out in many papers where the mortality has been very, very high in those patients who have developed COVID infection along with the IPF. Is there a role of antifibrotic therapies in COVID-19? For antifibrotics to potentially work in COVID-19, they should have a rapid onset of action. We don't know that as yet. They should usually be instituted early before mechanical ventilation. And then there are a lot of other issues. Currently, not enough evidence for empirical off-license treatment. We must remember that the fibrosis that occurs in COVID-19 is post-infective fibrosis, unlike what we see in IPF or other autoimmune diseases, which the fibrosis is more immune mediated. But it's still important that we need to see whether antifibrotics can prevent severe COVID-19 infection or acute exacerbation of an existing ILD in an existing ILD patients. Can antifibrotic prevent fibrosis in COVID-19 patients without ILD? And can antifibrotics mitigate or treat fibrosis in severe COVID-19 patients without ILD? I think we need more data to be really able to answer these questions. There are certain research considerations for ILD in COVID-19 which have been now flagged, and these are basically looking at the impact of COVID-19 on patients with interstitial lung disease, the impact of COVID-19 in ILD, the biology of COVID-19 and ILD, and impact of ILD medication of COVID-19. And there are a lot of questions which I think are important areas of research as we move ahead in trying to manage patients with interstitial lung disease and COVID-19. So to conclude, the diagnosis of IPF is multidisciplinary and multidimensional. It has to be a MDD approach, and that is something that we've learned, and it's something that we must practice regularly. Antifibrotics are now the mainstay of treatment of IPF. They are definitely slow the progression of disease, and therefore I think we have to be very clear that if you have a definite diagnosis of IPF, there is no other treatment strategy other than looking at antifibrotics. COVID-19 has affected care of patients with ILD and impacted management decisions in a very big way. It has led to diagnostic and management challenges. IPF patients have a higher mortality with superadded COVID-19 infection. So there is a very important need that unless we are able to vaccinate them, we have strategies in place to really protect our IPF patients from getting an exposure and thereby getting COVID-19 infection. And therefore, non-essential contact with healthcare services should be avoided during high burden of the pandemic while mitigating delays in management. So this is where telemedicine and telehealth will come in a big way. Pathophysiological and clinical characteristics of lung fibrosis after COVID-19 needs to be further studied to develop effective preventive and therapeutic measures. This is something where there is a lot of research which needs to be done. There was a lot of interest even after the H1N1 pandemic, which also led to not to this magnitude, but some degree of acute interstitial pneumonia leading on to pulmonary fibrosis. And there is a need for further research on the clinical course of COVID-19 in ILD patients. So I'll stop here. Thank you very much for your patience listening.
Thank you very much, Professor Guleria. I think you have given a very exhaustive summary